Welcome all to the Brain Health and Wellness Initiative series. Tonight, our presenter is Dr. Elizabeth O'Toole, and she is presenting on healthcare decision-making for progressive diseases like Alzheimer's. My name is Hannah Doles, and along with my colleague, Nicole Herbert-Hale, we provide care navigation in the JFSA Dementia Care Navigation Program. Our program establishes an empowering environment to help improve the quality of life of those with dementia or at risk of developing dementia, all while helping family caregivers reduce the stress and burden that often occurs while caregiving. At JFSA, we understand the importance in working with our clients' strengths and applying a person-centered approach to care, which extends throughout our multidisciplinary team of geriatricians, nurses, social workers, and geriatric psychiatrists. Nicole and I meet our clients where they are at and develop individualized care plans that help produce solutions to presenting problems. From linking persons with dementia and their families with community resources to following them with their medical management, we are their point of contact for guidance, as well as a listening ear. We consider the intersectionality of one's life when creating interventions that adhere to their biopsychosocial needs and experiences. Just a note, we will be taking questions at the end of Dr. O'Toole's presentation, and you will see a Q&A box at the bottom of your Zoom screen, so please feel free to send us a question at the end of our presentation today, and please refrain from using the chat button. We also give continuing education credits for these presentations, and it will take about 30 days from the date of your application, which is after the completion of a survey that is emailed to you, and you will then get your CE credit. So again, it will be emailed to you in the coming days after this presentation, and please submit your email address that you use to access the webinar so we can make sure we know who you are and send the right certificate to you. And if you have any questions at all about the CE certificates, feel free to contact Nicole or myself on that. Dr. O'Toole graduated from the Case Western Reserve School of Medicine and completed residency in internal medicine with fellowships in general internal medicine, clinical ethics, and geriatric medicine at Universities Hospitals of Cleveland, the Cleveland VA Medical Center. She is a professor of medicine and bioethics at the Case Western Reserve School of Medicine. She has over 30 years of experience in medical practice, focusing on geriatric medicine and palliative care, with an overall goal to provide patients and families with individualized care, education, and support. She has practiced at Cleveland VAMC, and most recently at Metro Health Medical Center, where she started and directed their division of palliative care and initiated the Hospice and Palliative Medicine Fellowship Program at the Case Western Reserve Metro Health Program. She also has worked and directed multiple externally funded research and educational programs. In addition, Dr. O'Toole has been involved in education and care through many community-based programs and has been a geriatric care consultant for Jewish Family Service Association, Jewish Association of Cleveland for several years. Thank you, Dr. O'Toole, for being with us today.
Thank you, Hannah. It's my pleasure. Welcome, everybody. Our topic today, as Hannah explained, has to do with healthcare decision-making in progressive diseases like Alzheimer's. And for this group, obviously, that's what we're going to focus on. It's not a topic that everybody is happy to have to consider, but it is an important topic. So I think it's worth our time to spend a little bit of thought on it. The way I look at healthcare decision-making in progressive and late-stage diseases is really from a point of empowering folks to make good decisions. A lot of times, many times, I hear from patients and families that they feel like they get kind of railroaded, that things happen and we don't have a lot of control over them. And this is a way, what we're going to talk about today, that we have of empowering some thoughtful late-stage disease decision-making. And I hope that that's more clear as we continue on our discussion today. Our overall objectives also include improving the ability of caregivers and patients to the extent that they can to manage decisions in crisis situations by reviewing common situations today so that they can be just, kind of thought about and considered in advance of a crisis situation, because these are the kinds of things that many people face in the future. And to understand the benefits and burdens of some of those end-of-life interventions that will be possibly considered, and improve understanding of hospice issues and advanced directives, which really are some of the tools that we use to manage late-stage disease. Next slide. Thank you. My plan to accomplish these things. So first, I'm going to review some common end-of-life medical issues for dementia patients, the causes of death that happen in that situation, so that we can facilitate thinking about decision-making. It's hard to imagine the universe of all things that can happen to people, but maybe we can discuss some of the more common things so they won't be so shocking should they occur. We'll review perspectives in considering late stage of life and reasons to give consideration earlier to healthcare decision-making. That applies not only to our loved ones who may have dementia, but to really anyone who is at some risk of having a significant health event. We'll discuss specifically advanced directives in Ohio, and as you'll find out, they are specific to the state, and hospice considerations, as I mentioned before. And as Hannah mentioned, questions will be welcome. So please do share anything that you are concerned about. Oh, Hannah, I'm about to push a button out of control here. All right. So to begin with, let's just review some of the a selection of the dementia diagnoses that people find themselves dealing with. Most common we know is Alzheimer's disease, but we don't know as much as we will know about it. For example, it's the most common, 60 to 80%. That's quite a range. We don't have a lot of specificity around that. It's a progressive neurodegenerative disease. So it's a degeneration of the neurology of the patient, of the nervous system, that causes other problems, including cognitive problems, thinking problems, neurologic dysfunction, movement problems affecting a lot of activities, speech, swallowing, speaking, communication, incontinence. These are things that happen over time, of course. Abnormal buildup of amyloid plaques and tau tangles in the brain is what causes this. And the prognosis usually, these are just ranges for people to have for planning purposes. They don't necessarily apply to any individual specifically, from 8 to 10 years from diagnosis, but as we know, people are diagnosed at various stages. Some have been extended to 20 years. Vascular dementia is the second most common. That's a result of microscopic bleeding and blood vessel blockages in the brain, also called strokes, but in this case, it's usually multiple strokes. There's shared risk factors. So patients who have a vascular dementia and have a vascular disease, meaning blood vessel diseases, also tend to have heart attacks and heart disease, which is obviously a life-threatening situation. And so the prognosis for that type of dementia tends to be less, 5 years, because of the other medical issues such patients deal with. And there's something called mixed, which means we really don't know. There are lots of different types, or there may be 1 or 2 or 3 different types of dementias operating in the same patient at the same time. Yeah, thank you. Some of our folks have what's called frontotemporal dementia, and you may have seen that in the news recently because of famous people having it, associated with clumps of abnormal protein again. but it's a different type of protein and it's forming inside brain cells again, mostly in the frontal and temporal lobes, so frontal and the sides of the temporal lobes, which are damaging cells and stopping them from working properly. And that affects a lot of language and confusion as a result. And that prognosis is 6 to 8 years. Also, Parkinson's disease, which is a relatively common disease. Not everybody develops dementia from Parkinson's disease, but many do in late stages. Something called Lewy body dementia, which is really associated with movement disorders, with a movement disorder. Parkinsonism, and it's not Parkinson's, but it has movements that look like Parkinson's. Cognitive fluctuation, so it's not a consistent and steadily progressive thing as much as some of the others. Visual hallucinations, a sleep disorder, and that prognosis is 5 to 8 years. But again, this is a range that we don't have real clear specificity. 2 to 20 has also been discussed in the literature. AIDS is also, advanced AIDS can result in dementia. Okay. I've got something on my screen that's covering up part of the slide, so I'm just going to look elsewhere. Okay. So reviewing perspectives and reasons to consider future healthcare decision-making early. I think we have to, in terms of perspectives, we all have our own perspectives on life. And when we're talking about healthcare decisions or any kind of decisions, or even just contemplating late stages of disease or end of life, we all have our own thoughts about that, whether they be based on experience or culture or religion or whatever. But ultimately, we all have to kind of grapple with this notion that this life is temporary. And that means we have to think about, or we all experience an end to this life. So it's not as if we can avoid this situation. And much of what happens to us is not in our control. Nobody asks for these diseases. Nobody asks for any disease, but they happen to us. Many other things happen to us, truly not in our control. But how we deal with what happens to us may offer us an opportunity to make choices that are most consistent with our own beliefs and wishes and caring for each other. So that's to say that in certain circumstances that are stressful and distressing, that we are saddened by, but are unavoidable, if we have an opportunity to make our path decisions based on our beliefs, our wishes, and by that I mean family and patients, and the care that we have for each other, we're going to make decisions and choices that are better than decisions that are made because of a need to act fast, a not thoughtful approach, anger, distress, other emotional burdens that don't allow us to think carefully. So those of us who are making decisions for other people or pondering what might be good paths for our loved ones, among ourselves, among our family members, or with the people for whom we provide care, understanding the perspectives, and there are many domains to think about: physical symptoms, emotions, beliefs, goals of those for whom we make decisions. And for most people who have dementia, they are not making decisions at the point of late stage, as well as our own perspectives. So the decision maker has all those perspectives of their own, and they also have to be considering, what do I think my loved one or the person I make decisions for, what do I think they would think about this if they could tell me about what they think about this at this point? So we make decisions as well as our own perspectives, are they important to consider both sides, because both the patient's perspective and our own as decision makers, those things are both going to weigh heavily as we decide things. Obviously, that's best done not in a crisis. So as I was mentioning, trying to have some idea of things that might happen because they're common to happen wouldn't be a bad idea to explore, so that if it does happen in your circumstance or to someone you know, you have some idea that, oh yeah, I've heard that before. This is not as shocking as it might be. I kind of get what it means. So I'm going to review just a few of the common end-of-life medical issues and the things that have been listed as causes of death for patients with dementia. Patients with dementia rarely die of actual dementia, but the other things that happen to people with this problem. So the most common one is called aspiration pneumonia, and that's due to difficulty in swallowing that's caused by the neurodegenerative disease. So on the certificate, it might say dementia or Alzheimer's is the cause of death, but the real actual thing that caused the patient to die was called aspiration pneumonia. It comes from an inadvertent inhalation. That means food, drink, gastric juice goes down into the lungs. Not that they inhaled it through their nose. Well, that could happen as well, but mostly it's swallowed wrong, so to speak. Went down the wrong pipe. Mouth and throat bacteria go to the lungs, and that leads to the infection of the pneumonia. Older people in general have an impaired immune system, and often people with dementia are in that category. And that leads to a worse prognosis, making aspiration pneumonia often fatal. Stroke and heart disease are common in aging generally, and as we mentioned before, certainly common in people who have vascular dementia. So those kinds of things can be lethal. Cancer, unfortunately, having dementia doesn't make you less likely to have a cancer. You can still have those many other awful diseases, and issues related to cancer lead to death because of the cancer itself, or complications from the treatment thereof, or choices made regarding the treatment because of the health status of the patient. In older adults with poor performance status is the phrase that we use, which means they have lost capacity or lost abilities by the time they've got the cancer and they're considering for treatment. You have to have a certain functional ability to really qualify for treatment of cancers often. And so these folks are not candidates, so the cancer does not get treated as aggressively. Other infections is also quite common. Many of us have seen our loved ones or patients with dementia have urinary tract infections, which are very troubling, sepsis, and can get out of control. Septicemia, which is one form of that out of control infection, which is it means it's infection that we've now found in the blood, so it's not localized to any particular organ. It's and that's more difficult to treat and more serious. Infected bed sores can be a serious problem for people because they're hard to treat if they get advanced. Dehydration, which can be related to infection and fever, can in itself be a very difficult symptom and lead to worse prognosis. And fever after antibiotic treatment. That is, we've treated an infection that what we thought was an infection, the patient has still got a fever. Now what do we do? Patients with diabetes can have significant complications from their diabetes that can lead to death. And commonly in the elderly, and particularly in folks who have dementia, we have falls with injuries. Lots of people fall. We don't want them to fall. We try to do what we can to avoid falls. They often happen anyway. And not all falls are accompanied by injury, but some are. And such serious outcomes from those injuries are fractures, or even more problematic, are head injuries. And thinking about, okay, we have a patient who has advanced dementia Now they can't walk, they have falls, and they've hit their head and they have a significant head injury. How will we respond to that? Dysphagia, which is a word we should learn because it's so common for people with progressive dementia, trouble swallowing, raises the question of how are we going to deal with that? Because swallowing is an important thing. How are we going to get our fluids and nutrition if we can't swallow? And it means that if we're trouble swallowing, that aspiration that we talked about before is much more likely. It's uncomfortable for patients, coughing, choking. And feeding tube placement is often discussed. We can discuss feeding tubes as, I don't know how many of you have actually seen a feeding tube, or perhaps you've seen people with them, or your loved one or the person you're caring for has one. But they can either be through the nose down into a tube that goes from the nose down into the stomach, and initially as a temporary feeding tube, or they can be as a more permanent feeding tube put in a procedure through the stomach, through the abdomen, from the outside to the inside, and then not food that you would recognize as food, but a material that has the components that patients need nutritionally is given to them through that tube. The American Board of Internal Medicine had a program called Choosing Wisely, where they evaluated several procedures or treatments for older adults for their efficacy. Are they good? The outcomes really seem like a benefit burden ratio is a positive one. And in looking at feeding tubes in the context of advanced dementia, they did not find any advantage to a feeding tube over careful hand feeding in end-stage dementia. There were similar complications, the same risk of aspiration with careful hand feeding was seen in patients with feeding tubes. So feeding tubes did not eliminate that aspiration risk, so they came out with suggesting that really that it wasn't advised. This is a picture of a gentleman who he doesn't look happy, and it doesn't mean to communicate that feeding tubes make people unhappy, but it was hard to find pictures of people with them. And to be fair, I don't think a lot of dementia patients in particular do tolerate these well in the nose, because they can't remember why they're there, and as you can imagine, having something in your nose taped to your face is, if you don't remember why it's there and you're not buying into the reason for it, it's a troubling thing. And so they don't last very long after being placed for many people. Next. Other things that people may find themselves attached to, and decisions have to be made, include ventilators. This is where a person has got a tube down their throat into the trachea, the windpipe, that is attached to a machine that does the breathing for them. They can't talk when they have that in. They have to have a feeding tube because you can't swallow. And sometimes have to be sedated because it's a very bizarre feeling and people are not comfortable with it. So ventilators for people who cannot breathe on their own are one of the things that is often an issue at end of life, to use or not to use. And then this is another one, dialysis. This is something that's not specific to end of life, because a lot of people with kidney failure are on dialysis, where they go to the dialysis center often 3 times a week for several hours a day to get their blood sort of cleaned, the function that the kidneys are no longer performing. Blood comes from the patient in through the machine and goes back to the patient. There were some symptoms associated with that. A lot of people have symptoms that include very fatigue, nausea, trouble having to deal with that every couple of days, having to go there for several hours, just not feeling well, feeling sort of wiped out afterward. But it is, it replaces a critical function, and many people live years on dialysis. Whether it's something that people would want if they don't know or can't participate with the nursing staff in understanding what's going on with them so that they can put up with this is another consideration in late stage dementia if people turn out to have kidney failure. It's not the same kind of experience for the patient if you can't participate in what's going on, understanding why this is being done and what the gains might be for the person. Next, there we go. So what are our social responses to some of this decision-making stuff? I'm thinking most of you have heard of advanced directives, but I know that some people have not. And since this is a big component of how we formalize decisions in advance, medical decisions in advance, I'm going to go over just a little bit about them. It's amazing to me that they've been around for as long as they have, because I remember when I first started teaching in this area, this was new stuff, but that wasn't yesterday or the day before. 1991, so it was a while ago. And it was started with a federal law, not a local law, a federal law that was called the Patient Self-Determination Act. So you can kind of see where it was coming from. It was coming from a consideration that maybe patients were not allowed to self-determine, that we weren't focused, we as a medical profession or healthcare professions, were not focusing on the rights of patients to determine what happens to them. And maybe there were some ways we could do better with that. Now, so this law or act of 1991 requires all healthcare facilities to provide all patients upon healthcare program admission. So you've heard maybe every time you pop into one in or out of these healthcare facilities, somebody's mentioning this to you, but it might get lost. Information about the laws in their state has to be part of information that's provided to people, specifically regarding documents called durable powers of attorney for healthcare and advanced directives, which also include living wills and resuscitation orders. Facilities are required only to inform patients about these things, not to promote or require them. And facilities do have to provide information. They have to have a policy about living wills and durable powers of attorney for healthcare. And they have to provide forms if you ask for them, and they have to keep records. So theoretically, if you complete these documents, turn them into the facility, whether that be your hospital system or your doctor's office or your nursing home, they're responsible to make sure they keep a copy of those records and that it's available. Obviously, the person who puts it into the system, either on the patient's behalf or the patients themselves, need to keep their own copies. Okay, so we'll take them one at a time. There's not that many, so it won't be too painful. The Ohio Durable Power of Attorney for Healthcare and Living Will documents were recently, well, sort of recently updated, 2016. Those forms do look a little different, but if you have a form that was executed prior, they're still valid. There's no question about it. You don't have to upgrade. If you want to, you can look at it and see. Issues are specifically addressed in that law that we talked about, that person's right to options under conditions of two specific conditions: permanently unconscious state or terminal illness, and unable to make decisions. So your durable power of attorney for healthcare will not be making decisions until you, as the patient, are unable to make decisions. Until that time, you make your own decisions. And it can make you can make decisions that are not in agreement with your document. Decisions may involve initiation, withholding, which is not giving, or withdrawing, which is a life-sustaining treatment has started and you're going to stop it. And it includes withdrawal of artificially supplied nutrition and hydration, which is back to the feeding tube, or it can also be given by intravenous, but that's not the more common way. Some people were worried. So I want to be clear, the Ohio law does not authorize euthanasia or assisted suicide. That is still not something that's tolerated. Hospitals and physicians, however, are not required to withdraw life-sustaining treatment when such decisions are in conflict with the physician's conscience or the hospital policy. So if family is asking that something be done that the physician feels is not ethical, the physician is not required to do it. They are required to either turn over the care of that patient to somebody else or to take it to some more review to see if how that can be worked out to address the patient's rights and wishes while still remaining consistent with ethical principles. Physicians and hospitals cannot block a transfer of a patient to another facility, which means if you're in a facility and you want a certain treatment stopped or given, and the people there don't believe that they can ethically do that, and you found someplace else to take the patient, that transfer cannot be blocked by the original facility. They have to support that. So the durable power of attorney for healthcare, what does that mean? Adult patients with capacity to make decisions may appoint someone as their agent to make healthcare decisions for them. Should they lose the ability to make decisions for themselves, that can be temporarily or a permanent loss of capacity. The person doesn't have to be a relative, does have to be an adult, and does have to have capacity themselves. The updated form that I mentioned, 2016, allows patients to give the agent access to healthcare information prior to loss of decision-making capacity. So there's a little box that they can check that says, this is my agent, and you can tell them, you can give them information about my health status at my signature here. It doesn't have to wait until I do not have capacity. That doesn't mean they make decisions, but they have access to the information. Patients may state their wish, that is, give authority to somebody, to avoid artificially provided fluids and nutrition in case of a diagnosis of a permanently unconscious state. There's a lot of discussion in these documents of permanently unconscious state. It's kind of a rare thing. It really doesn't happen all that often. It's an extreme condition, but it is helpful to know, to sort of at least ground the understanding of what this person would want in the most extreme situation. The other advanced directive that's in this same regulation is a living will, which applies to individuals in that specifically in a terminal condition or a permanently unconscious state. Although patients can write in more other things. I mean, this is what the standard one is about, but they can write things into it. And it's compelling in the same sense that if we're asking for direction and you've written in your document, this is what I feel about thus and so, I mean, we really are not in a position to ignore that. Other documentation may give valuable evidence. So it might not be one of these documents, but they may have written a letter, or they might have some other documentation of a patient's wishes, but it doesn't have the same legal standing, but it does, any clear information, especially if it's consistent information over time about what patients want, is very important in the discussion. In talking about resuscitation, which is, I was in the hospital several weeks ago, and although I've been teaching about this for, as I kind of alluded to, many, many years, it was a different experience when I got to my hospital room at 2 o'clock in the morning. And, after my name, rank, and serial number, the nurse asks me what my DNR status was. And I thought, wow, this is what that feels like to be asked those questions. They ask everybody about that. Having a good answer is probably a good idea, and not a reflex one, but something that's somewhat thoughtful. The way that this do not resuscitate issue is categorized in the regulation is really around comfort care. It's about, when do we switch our thinking from making care decisions and treatment decisions about attacking a disease process and trying to get a person through it and better, to whatever's going on now, I'm going to make my decisions about treatment based on what's going to make this person comfortable. Because a lot of treatments we give for diseases don't make people comfortable. They may or may not make them ultimately feel better or live longer. But this is now focused on comfort care. So it's a DNR comfort care that is what they're really writing. It means they're going to withhold or withdraw artificially or technologically supplied nutrition or hydration for the permanently unconscious state, and they authorize that. And the DNR order, this means, as I said, take no action to postpone my death, providing me with only the care necessary to make me comfortable and to relieve pain. So this is just sort of another way of looking at how that is stated in the regulations. If there's somebody who is in a permanently unconscious state, the physicians, I mean, people are trying to make people be very careful. This is an okay thing to do, to not give these treatments, but we want to make sure that we're doing it under the right circumstances. Patient's physician and at least one other physician who's examined the patient, and they've all determined to a reasonable degree of medical certainty, which is a very interesting phrase and hard to know what that actually means, that artificially or technologically supported nutrition and hydration will not provide comfort. We have no reason to think for most people that it would provide comfort, as long as we can are able to provide medication as necessary to control pain. Okay, so this is sort of the specific reviews here thing. So living wills, if the documents are living wills, or they address organ donation, they're durable powers of attorney for healthcare. Those are all advanced directives that are authorized by state law. The do not resuscitate comfort care, which means only treatment that advances patient comfort, has two triggers. That is, we start this status of only treatments that advance comfort either after a cardiac arrest, so we don't do CPR, we don't do anything but make the person comfortable, which is DNR CCA, or immediately. Because of this diagnosis and the patient's condition, they have not had a cardiac arrest, but we're right now, from now on, going to just consider treatments that are going to advance the patient's comfort. And that's called the DNR comfort care status. These things are important because they're portable. The DNRs are portable because you could have a cardiac arrest anywhere, right? You could go to a hospital for any number of reasons. And if they didn't know that this was your preference and that you had taken the time to have this order written, you wouldn't get the treatment that you wanted. So they're portable across venues of care. So this piece of paper that you get, yes, actually still paper. There is electronic in the hospital system, but you actually have a piece of paper that we actually ask people to have in their homes. so that it will go to the hospital, it will go to the home, it goes to the facility, wherever you are. EMS will respect it if they see it in your home. If you call EMS, which you could do, when you fell, you broke your hip, whatever, you need them. They need to know that that's your status as far as resuscitation goes. And so you should have that piece of paper at home to show them. So that can cover whatever treatment you may be considered for you, even while you're in the ambulance. So what happens when patients get to a point where we're thinking about hospice? How do we know when that's something we can think about? Well, hospice is appropriate for patients with late or end-stage dementia. They have specific criteria, which I'll talk about. It's provided by a certified hospice organization, and that certification process means that they all should be following the same rules about what stands as qualifications for a patient with dementia to get hospice services. There are some advantages. They have a team approach. They're required to have a team approach, a multidisciplinary approach, including nurse, social work, spiritual care, physician, who meet with the team of people, that whole team, every 2 weeks, and they sign off on orders. There's a medical director involved with doing that too. That's the physician. And they're also available for consultation. It can be provided, the services can be provided in home or in a facility, or they also do provide something called respite care, which gives the home caregiver a break for a certain amount of time, and that's covered by sending in somebody to provide the care. The care is provided for comfort, including related meds and equipment and supplies. All that's covered, is typically covered by insurance. But care for ongoing other diseases may not be covered unless they're needed for comfort. So if you're taking some medications to prevent a future problem, like you're taking a cholesterol lowering agent for your heart disease, that kind of thing might not be covered. But if you are taking something for chest pain or something for making your breathing better, those things would be. And they're available for home visits, which is a very nice thing for people in late stage because getting around is not easy. They come routinely. They will also plan visits. And they're available at least by phone 24/7. And if necessary, they can come out for an emergency. So they're kind of trying to avoid having to bring people to hospital and disrupt a whole comfort approach. So having covered all those things, what would we recommend? Well, some thinking. So consider what might be expected to occur in the future for your loved one, knowing that we will never be 100% able to predict things, but we can see maybe trends and the likelihood based on what's already been going on, given the medical situation. Consider advance directive related decisions and thoughts. If the person we care for is able to weigh in on those things, get their opinion on it. If we're left with a history of what they've said and what they've done with other people or thought about, it's good to document that so that everybody's on the same page. And families, family decision making can be a source of difficulty. People don't get along or don't agree. So thinking about those things in advance, so when emotions are at their highest, we're not putting the most stress on people, but we kind of have an understanding. If appropriate, we should consider advanced directives for ourselves. We've had another program called Advanced Directives, a Gift for Your Family. Take the burden off others by making it clear what you yourself would want. For most of our dementia folks, that ship might have sailed, but for the rest of our families, we could think about it, share our thoughts about our wishes with family or other potential decision makers, or one should consider the benefits and burdens. I think that's probably a key point, is we can get overwhelmed with people coming and saying, well, what do we do? What do you want us to do? Well, that's a kind of question, but it's not the easy one to answer. The way we want to think about it is what's the benefit here and what are the potential burdens of a specific procedure under consideration or a treatment under consideration, and conscientiously judge whether or not that ratio, that benefit to burden ratio, makes sense. If patients not able to provide input, and consider thinking about the lifelong wishes or expressions that I just mentioned. What would be most important or most intolerable to this individual? Thanks, Hannah. I want to remind you that you do have the right to ask questions. You might not where to go. You might not know where to go, and you might not have people who respond to your questions the way you'd like, but you still have that. There's nothing wrong with doing that, making that effort. So check with people you can check with our primary care provider, the provider's office, a geriatrician, or some other advisor. If you're concerned about late stage issues, symptom management, you can, all those people you can work with. There's also palliative care consultation on most of the major systems. It's not the same as hospice, lest you be confused, but it can help with that recommendation if it's appropriate. There's much information available. There's a lot of stuff on the internet. Most of it's relatively reasonable, but we can raise questions, and even if it raises more questions instead of answering them, then you have to talk to people you trust and those who have experience. And this is not something people need to do in isolation. There's information out there, and there are people who, at JFSA, there are lots of people who can help process information with you.
Thank you so much. I think we appreciated all of that information. I know we may have a lot of questions, so feel free to use the Q&A box, like I mentioned, and send in your questions. And I actually have a few to start with.
Okay.
All right. Does a history of alcoholism predispose an individual to a specific form of dementia?
Well, there is an alcoholic dementia. It's sort of like a poisoning. So it's, but we can, it's an aspect of the alcoholism. It's an end stage alcoholism finding. There are there's often liver damage from alcoholism, which makes thinking a problem, and confusion and so dementia occurs from that for that. I did not mention that as a cause, but absolutely.
Thank you. Someone else wrote, when is a person considered unable to make a decision?
That's a great question.
Mm-hmm.
So there are criteria that we use. You have to be able to understand the question that's being asked. You have to be able to respond, express an opinion on it. You have to be able to make a choice. You know, you have to be able to discuss, be able to weigh the choices, and you have to be so it's a problem maybe specific to the decision. So somebody may have enough wherewithal to understand a particular decision, but not be able to, you know, buy groceries. So a clinician will make a determination for serious decision making around healthcare, specific to this decision. Does this person know what they're talking about, and can they weigh the options? Can they express an opinion that then about those things? Then maybe they have capacity for that decision. It's not a global situation. It has to do with the decision, but it's a really good question, and it may vary. It may even vary between times of day for some of the folks as they're, you know, with sundowning and whatnot. But it's a really good question.
Mhm. Thank you for that. What are the steps to take once a POA document is created? Are there any particular providers or people that this should be sent to?
hmm Well, in the creating of the document, the signature of the patient, and not interestingly enough, the power of attorney for healthcare doesn't have to sign it. The person who's assigning uh, the authority to the power of attorney is the one who has to sign it. That signature has to be witnessed by two people. And there are specific people, obviously the doctor can't do it and people who are named in it can't do it. But it has to be witnessed by two people or notarized. Notary public has to notarize it. Then the patient and family should keep copies. The provider and now the way medicine is practiced, the system should have a copy of it because everybody has their electronic record and it should be in there. So that whenever that person shows up in the system, they can look it up and find it there and they don't have to delay trying to get a piece of paper to be found and show up.
Hmm.
But for sure, besides the paperwork, for folks who have capacity to do that, the paper is important. It gives the person the authority to make decisions. But if there's been no conversation between the agent and the person who's giving that authority to the agent about what they want, the decisions aren't going to be that great. It's really it should be a reflection of the conversation that was exchanged, the information that was exchanged about the person's wishes.
Thank you.
And they exist until somebody writes a new one. So if you want to change it, you can change it, but it has to you get a new one with a more recent date, and ideally you get rid of the other ones, but that's more challenging.
What are the steps to get a DNR order?
That is different in that requires a provider's signature as it's an actual order. You can sort of think of it as a prescription, but there's no drugstore involved or pharmacy. So you'd have to talk to whoever your physician or provider is about the wish for one and why. And if they agree and think it's a reasonable, a good conversation, and they can provide a signed order to you and put it into the system as well. But again, you should have a copy at home.
Can you talk a little bit about, for the DNR piece in particular, do you have, I've heard that you should put it on a refrigerator or because the EMS teams look for that. Do you have any other tips on that?
That's exactly right. That's exactly right. Because EMS, those folks are great. I mean, they go into really tough situations. They don't know what they're going to find. And they want to do the best for people, and they're busy. So we cannot expect them to look around for where would I put that? Where would I have put that paper? So we do tell people to use the refrigerator because most everybody in most apartments or living houses or those sorts of places do have refrigerators, and they're easily located. So we do tell people to keep them on the refrigerator. So because EMS is not going to scour any place to look for it. If it's readily available, or if somebody brings it to them, like whoever else is in the home brings it to them, they'll happily comply with it. But you're right. If a consistent place that's kind of been, it's just what we recommend is the refrigerator.
Sure. Thank you.
Mm-hmm.
Another one came in here. When you have a POA for healthcare with approval to get health information and the provider refuses to release the information, what can you do?
Shame on them. And they've seen the document. That might be
yes.
Yes. I was trying to defend them here. I don't, that seems kind of indefensible. So I wonder why. I'd ask them why. I mean, there needs to be a reason for that. It's a newer thing. to
Mhm.
have this little box you can check that says, I immediately give them, I don't know if that's exactly the language, but that's the gist of it. Immediately give this person access to my healthcare information. If they, for some reason, suspect that there's not good things going on, that this person really didn't want that, or that this person is abusing in some way, that's a different story. But then it would be on the provider to explain why they're not doing it. And if there's another provider, you could ask that person for the information. But yeah, I would ask them why. I mean, I've got, this is right in front of me. Well, how are you interpreting this differently from me?
Someone did want to comment on that they had, they're the power of attorney for their brother. So
Mm,
I had to get my brother's elder law attorney to insist that the POA was effect. So I'm taking
they
it that
did.
they had an attorney call to ensure that
That's unusual.
I have seen with the health systems an additional paper for a HIPAA release for medical records. So I'm not
Yes.
sure if maybe that's maybe an additional piece the answer or the office would need.
Yeah, and unfortunately, there are different sort of levels in medical systems now.
Mhm,
So there's the medical records department, who, well, they'll release, if you want them to release records, that's different from
mhm,
sharing information from like the providers telling you what we talked about in the appointment, you know,
yeah.
because medical records involve a lot of things. Uh, and that would require a HIPAA release, a
Mhm,
signed HIPAA release, but that person would have the authority to sign that release,
mhm,
or should,
mhm.
based on that document.
Thank you.
If the patient still has capacity, then, you know,
Mhm, mhm,
why are we not talking to the patient about this and saying, having the patient say, look, I signed it, let them
mhm.
tell them what I want. And that should not be ignored. I'm sorry that that person had to go to attorney if that's what happened. Nothing's perfect.
I think we have time for one more question. Um, what happens when POA documents are not put into place and an event happens
Yeah.
and a family member isn't elected?
Yeah.
What are the steps to take then?
A family member isn't what?
Isn't elected as their
Oh,
POA.
isn't designated.
Mhm,
Well, they're called non-declarants. There's a word for those.
hmm,
People who have not declared who's their representative, and they are, the law actually does address them too. So it is family who is first. Well, it's a guardian first, but that is a different special case. So the spouse doesn't say anything about the quality of the relationship, but the spouse would be the first one.
mhm,
And I've had several patients who, it's an sort of an estranged spouse,
mhm,
haven't seen him in years, but they're still legally the spouse, then they are the decision makers legally.
mm,
Yeah, so think about that. Then children, adult children, and if there's more than one or whatever, however many, it's the majority if there's
mhm,
nobody designated. So if you have 5 kids, we got to have 3 kids agree to something.
mm,
So that's not always the simplest thing to do. Um, uh, then parents and siblings, and the siblings are the same thing, majority rules.
okay.
Um, so there is a sort of a hierarchy, if you will. So it's another reason to think about having these documents. If you consider, oh, those are not what I want, then make sure that you put what you do want, or think about how, or talk to the family and say, well, amongst us, who would we think would be the best
Sure.
to be the spokesperson, maybe, or how will we include everybody, or have a strategy?
Mhm,
Because truly in a emergent situation, that would be a challenge when everybody's again, emotions are high and people are very stressed out, and
mhm,
trying to get together and get along may not be the easiest thing. But if there's a plan in place, if anything happens to mom,
mhm,
here's what we do. Um, and that doesn't have to do with these forms. That has to do with just thinking about it and making a pact if you want. That's a good question, but it is in there. It's documented what the hierarchy would be.
Good to know. Thank
Mhm.
you very much for all of
Good
it.
questions.
Yeah. So I know these are some resources you put together. So if anyone is interested, we will be sharing the slides for those who attended the program tonight. So you'll have copies of this and where to look things up if you have questions on where to find the advanced directives packet and some of the information we talked about tonight. So again, thank you all for joining us tonight. And Nicole and I are a part of the Alzheimer's disease and dementia support program. So if you have a family member that you are looking for information or referrals for services, we'd be happy to talk with you about how we help families in our local community. Our two geriatricians that work with us at our Allison's Place Clinic, Dr. Elizabeth O'Toole and Dr. Constance Magulius. Frank Petrelli is also part of our team. He helps us with our cognitive assessments. Pam Lynch, she is with us for our Caregiving with Confidence workshops, and she is also part of our support groups that we offer monthly. Leanne Stuver is a health educator, and she is also with us for our Brain Health and Wellness series. So a little bit of a summary regarding our program. We have Caregiving with Confidence workshops, which is more of an educational workshop for family caregivers. We are in the midst of one right now, and we will be offering it throughout the year. We have a support group for caregivers as well. We meet twice a month via Zoom. We have our support program, so our care navigators, Nicole and I, who I mentioned before. JFSA also has a variety of other services, such as our home care program, where we have skilled nursing, private duty aides that can come to the home and work with your loved one. And then, of course, our Brain Health and Wellness series that we offer monthly. Next month, Leanne Stuver will be with us on May 18th. So it is a week earlier than normal. So I did just want to note that, but we will be sending out invites for that program. And of course, if you have any questions at all, feel free to reach out to Nicole or myself, and we'd be happy to talk with you about our program or other upcoming events. Thank you, Dr. O'Toole, for joining us tonight.
Thank you.
And take care, everybody.
Bye.
Bye-bye.